and welcome everyone to this month's Policy Learning Collaborative call. And just ask you to keep yourself on mute until you're ready to speak. But of course, as folks who've been here before know, we want you to speak a lot. Also, feel free to use the chat box to pose any questions or share resources. And with that, I will turn it over to Sarah Holland. Thank you.
Co-chair this very fabulous NRT with the
Sarah, you sound far away now.
It's funny. I noticed I was saying something earlier and it sounded like no one heard me.
You're really far away.
Okay. Agenda is in the chat. I'm gonna quickly log on and log back off. Or you know what
I mean. So while Sarah's doing that, she said that the agenda is in the chat and she's going to be back in just a second. So I think first up on the agenda was to debrief about open mid-year and take a few minutes to do that along with any open announcements. So the floor is everyone's. Hey, Sarah, I was just saying that it looked like the first agenda item was open debrief. I'll let you take it away.
Oh boy. So it sounds like she's not able to connect to audio.
Tanya, do you want to take over while Sarah's troubleshooting, or would you like me to? Either one.
I super want to take over. Yes. Fridays are busy days, but I also get really goofy, so sorry. Yes, as Sarah and Annalise said, the agenda is in the chat. We're going to start by talking about just debriefing the conference last week. And I guess for those of you who don't know, especially, welcome to Dr. Rosier. We, Sarah Bedard Holland, Annalise Cawthron, and I are the co-chairs of the Policy Network Response Team. We are a little bit new in that role. We've all been on the team for a long, long time, but we've maybe it's about 3 months or so we've been in this role. And so we're happy to be working with you all on working on policy issues related to open. I also, one of the things we've been really working hard on doing is trying to connect all of the other network response teams to this team so that anything having to do with policy that may be happening in one of those other network response teams is getting into this room so that we can all make sure that we're kind of moving in the same direction and that the policy folks are aware and able to help move any of those policy issues forward. So that's a whole lot of context. Sarah, so we also take turns facilitating. It's not magical that Sarah's facilitating today, but it may be if she can actually be heard now. So I will pause 1 second to see if it's magical.
I have absolutely nothing to add other than I believe I can now be heard.
Yes.
So exactly what Tanya was saying about the open meeting and sharing and moving forward. And then I will catch up and take notes and then we can move on from there.
So this is the very general, what did y'all think about the meeting last week? There was quite a lot of policy pieces to the meeting, of course. There was I felt like I kind of popped in and out as I had other meetings I had to end up attending, so I didn't get to see everything, but there was a really great policy panel on whatever day it was, Wednesday. There were, I know Colin did a policy breakout session. Annalise and I did another policy breakout session along with Chloe from Virginia. I think there were some others as well. Certainly around talking about the blueprint, there were other policy discussions. So basically policy just kind of kept coming up all over the place. Everything's about policy after all. I'm going to just stop talking and just like, what were your thoughts, reactions? Did you hear something new? Do you some new idea you want to bring to this team? Something you thought was a little odd? Anything at all? Everything's a little bit odd.
I thought Amber Chris's session on waivers was excellent. And even though I know that has been presented, sometimes it's good to hear things several times. And that was one of my follow-up after the mid-year notes to myself.
Actually, Deb, I'm glad you brought that up because like I didn't get a chance to attend Amber's, so this is a great chance to, yeah, if there's something you attended that maybe highlight something great that you heard if everybody else didn't get a chance to attend it. So that's good. That's a good one.
Did anyone learn anything new from a policy session that they feel like would be helpful to share with the group? Everybody knew everything from the conference.
Y'all are so smart.
I
think-
did, like I said, I did. Go ahead, Vanessa, please go ahead.
Oh no, sorry. I jumped on late, and so I'm probably not in the same spot that you are. So, but the policy sessions at mid-year, the were a lot of confusion. So I don't blame anyone if there's a lot of silence. So.
And Vanessa, I think you might be referring to the policy, the blueprint policy sessions. I can't think of the policy lever.
Yeah. If you're somewhere totally different, sorry for interrupting.
No, you're not. You're 100%. We are in free fall right now, so you're completely fine. We were just talking about, just any takeaways, any reflections, reactions to the open conference last week. Obviously, focusing specifically on policy. There were obviously policy like presentations, but there was also the policy lever breakout group as well. And I think, and you're right, Vanessa, I was in one of those, and I know you handled it masterfully. I think it was a really challenging conversation because there was confusion around where things are, but I think you handled a challenging conversation brilliantly. So bravo to you. You weren't looking for a compliment, but you got one.
So I wasn't in that session, but would love to, particularly from a feedback that we can give to the open folks. Obviously, Stacy's here and can carry some stuff back, and representatives of NOCT. But is there something specific that would be helpful to carry forward related to that confusion that folks would like to share, or more comfortable just kind of venting about it? Both fine. Well,
Venting is totally okay. I won't take that personally. We just the policy, we just really need this feedback. So yeah.
Well, and Vanessa, I think one thing we really, I hope I can speak for the team. One thing I think we really do want to do is figure out to what extent can we do more cross-pollination between not only the policy NRT and the other NRTs, but also the policy lever. I think obviously seems like it should be an obvious match. So I think, and maybe this is just the day we say, gosh, we should start working on this together, and we figure that out in the future. But if I do feel like there should be some overlap and some conversation. I'm super glad you're here because I think we need you here at this team.
So I can just add something. Vanessa and I, we were in that session together and just chatted for a second afterwards. But I think my sense was that most people who came to it, kind of the theme of the session was, okay, what do you think we should be working on with policy, or what's going on that you want to share with other people? And I think most people in the room didn't have anything to say because they came there, I think, more wanting to be told what's going on or be told what they should work on. And so it was a little bit like pulling teeth, pardon the dental pun there, but it was hard to get people to volunteer much because they didn't have much to say. So that was one of the dynamics, at least from my viewpoint.
I think that's excellent feedback, Paul. And it does speak to why the value of kind of cross-pollinating across all these groups and levers and NRTs is exactly the right thing to do. I just realized too, I really should have said this like 10 minutes ago. Especially for not new people kind of come onto the scene in this team, which I think is wonderful. And in order to make it even more facilitative, why don't we all, when we speak, just remind everybody who we are and where we're from, so that especially, Dr. Rosia, we're super happy to have you here. You probably don't have all the background on everybody. So us, doing a smidge of introduction when we speak might be super helpful for you.
That's a great point. Thanks, Tanya.
Mhm.
Well, I want to be super mindful of time, and I think we do have an opportunity to dig a little bit more deeply into some of the Medicare stuff, and kind of particularly what Paul was just saying. We do have some direction that we know that we want to go down. And Chelsea, I also really appreciate at the beginning your candidness with the fact that you're representing the American Dental Association that may have some slightly different perspectives on this issue than Open does. I am of the mind that, Open is very transparent about what their position is. And so I don't think that I have no issue with having American Dental Association representation, even if it might be slightly counter to what the Open position would be. But I do want to note for folks that joined late that Chelsea offered to exit stage left or right if folks felt more comfortable speaking candidly without the Dental Association presence here. So I wanted just to make sure that that's noted. I'll note that in the minutes, Chelsea. And but if anybody does have anything to offer there, I want you to please feel free either in the chat or to speak up now. But super happy to say that we've got Colin, and I think Casey is on as well from Families USA, who can provide a little bit of background about where we are with Medicare and medically necessary services for oral health. We've gotten a lot of pretty great traction in the past, 10 days or so. And I think definitely some opportunities to submit some comments from Open, and also to encourage members of the network to submit individual comments as well. But just to make sure we're all at baseline together, I'm going to hand it over, to Colin first, and then Casey, if you are on, you're not showing up on my screen right now, but and have things to add, please feel free, and anyone else as well.
Sure, and I'm happy to, defer to Casey. I know that Families, Justice and Aging, and Center for Medicare Advocacy have really been, the leaders on this issue. But for folks, and by the way, sorry, I'm Colin Roosh, I'm with Community Catalyst. For folks who have not been following this closely, CMS, I think it would be safe to say directly in response to the advocacy that many of the advocates in Open have been taking on, issued a Medicare payment, a proposed Medicare payment rule that proposes to at least slightly expand the definition of medically necessary dental services in Medicare. So that is to say, the dental services that can be made available on the condition of, oral health's connection to specifically defined services or conditions. So, they are proposing to, expand it for a few different conditions or procedures. I think it would probably be safe to say that this is not as expansive as many of us would like to see. But there's an opening here for public comment to push the agency to consider a more expansive view of what dental services are inextricably linked to and substantially related and integral to the clinical success of other health services that might be delivered to a Medicare enrollee. And this is sort of where I think my expertise starts to fall off a bit, and I wish that someone like Wei Wei were on, because I think she has a much better sense for how stringent that standard actually is. But that said, I think our task right now is really to make the case to CMS that they should consider this as broadly as possible when it comes to oral health implications for the success of other treatments for other health conditions for Medicare beneficiaries. So I'll pause there and see if others have something to add. I do know that Center for Medicare Advocacy and others are in the process of developing some draft comments that we can all utilize and react to.
Yeah, Colin, I just would add that about just introduction, Paul Glassman from California North State University in Sacramento. I agree with you that this is one of those things where the devil is in the details, because Medicare already does include some medically necessary dental services. If you're in a major automobile accident and an oral surgeon needs to reconstruct your jaw, that's covered. So you could say they're already doing it, but obviously that's a very, very narrow definition of it. And I've been involved in this issue for about 30 or 40 years. There was a long time ago a medically necessary dental bill that was introduced and didn't pass. So I think really it's the details of what the medical conditions that are going to be considered to be medically necessary, and then what the dental treatment that's going to be considered to apply are the critical things to figure out. And if there's some way to know what they're thinking or advocate for a broad definition of it, I think that would be the lever we should be trying to pull on.
Yeah, I think this really does come down to, what clinical evidence can we leverage to make that compelling case. I'm sorry, David, I interrupted you.
Oh, not at all. No, please finish.
No, that was the conclusion of my statement.
All righty. Hi, everyone. David Lipschutz from the Center for Medicare Advocacy, filling in for Wei Wei Kwok and Kata Kertes, my much more learned colleagues. So I won't even pretend to know as much as they do, but and say, thank you, Colin's absolutely right. A couple of things I think Kata and Wei Wei wanted me to attend this call to also, convey is reiterate what Colin said about the opportunity to submit comments, because CMS does explicitly seem to be seeking comment on exactly what kind of conditions and situations it would be appropriate to cover, for medically necessary dental. So it's not a clearly defined standard at this point, and that's why it's important to have clinician voices comment and express support and explain situations in which oral health care would be necessary for other covered treatments to successfully occur. As Colin noted, we are working with other stakeholders to draft some proposed comments, but it does look like this wouldn't necessarily be the end. CMS is also proposing a process by which it would annually receive and consider recommendations for coverage and other clinical scenarios that might meet the standard. So now the best chances are really that CMS will immediately include dental treatment for pre-organ transplants, cardiac valve replacement, and a couple other conditions. But if finalized, CMS says that the Medicare contractors that process claims could decide to grant coverage on a case-by-case basis, applying the proposed standard. So not necessarily limited by what CMS chooses to recognize. And even though CMS currently, according to again, my more learned colleagues, currently views the standard as applying to dental treatments needed before a covered medical treatment, it is interested in hearing comments or input regarding situations in which dental treatments may be needed after a covered medical treatment, such as with head and neck cancer patients who've undergone radiation, or as part of an ongoing treatment or management process. So comments are due September 6th. As Colin noted, we are drafting some template comments, and any and all clinician support for particular coverage in particular situations would certainly go a long way towards helping ensure that this does become finalized. So thank you for allowing me to participate. Not that you had a choice, but thank you for listening.
But David,
Thank you, Dave. That's super helpful.
Got it. I'm sorry.
Paul, were you going to say something?
No, I was just going to ask David a question. What I'm hearing, and this sounds like has been the sort of general attitude previously, but I'm hearing now what CMS is saying, or saying indirectly or proposing, is that the dental treatment be limited to the kinds of dental treatment that would directly impact the outcome of the medical treatment. In other words, the idea of pre-organ transplant, pre-cardiac surgery, those are things where you're looking for dental infections that could possibly have the organ transplant or the cardiac surgery end up not being successful because there was an infection seeded from the mouth. So that's a fairly limited set of dental procedures in a fairly limited set of conditions. Is that do you agree that that's the general philosophy of what they're trying to put into place?
I think that seems to be the intent with, but maybe we'll provide wiggle room. I mean, that the exact language that Wei or Kata quoted for me was that the proposed standard is, quote, inextricably linked to and substantially related to and integral to the clinical success of certain other covered medical services, unquote. So yeah, it is fairly limited, although, again, they are seeking comment on what that would apply to. and are proposing a process where they would add to those things, and also seeking input on whether or not, dental treatments after covered medical treatment. Of a process, it's the opening of a door.
Yes, Chelsea.
Yeah, so just wanted to offer a few other thoughts as we have tried to digest the proposed rule and kind of how I'm thinking about it, but this is really just kind of a very loose outline, but as have been mentioned, I think there are a few things in here. So it's what medical conditions are substantially related to. And then, as David was saying, what are the dental services that relate specifically? So not just thinking about examination and extraction, but what are some other services that should be considered for each of those medical conditions that are identified? I think the treatment sequencing issue, again, that David just brought up is really important. So, to date, it's been like the pre-surgery sort of thing. So what sort of recommendations might there be related to, the sequencing of allowable procedures being in the best interest of patients and not just limited to beforehand? That future process, also I think the final notes in the dental section is on future payment and the opportunity to comment on innovations that should be suggested. And lastly, sorry, I'll stop, but I don't think this was mentioned yet, and I think it's an important piece, the proposal for paying for services in an outpatient setting. And I'll stop there.
Yes, Paul.
Yeah, just going along with that theme we've been talking about for the last couple of minutes, it seems to be one key thing that possibly there's room for advocacy on is, again, I think this is all pointed at dental infections that could possibly damage the other parts of the body where there's some treatment going on. That's the underlying medical theme here, is that you don't want the heart surgery, the organ transplant to not be successful because you got an infection from the mouth that went to this other organ. So when you have a tooth that's got some trouble with it, obviously the best way to prevent future infection is to extract the tooth. I mean, there's no question when the tooth is gone, it's not going to cause any more infection. But there are other ways to reduce the likelihood or even the possibility of infection by restoring the tooth or performing a root canal procedure or other things like that. So I think that the maybe a point of potential group advocacy could be around the idea of allowing a range of treatments to reduce the likelihood of infection rather than just what could be the lowest level, which would be anything that could be a problem you extracted, and that's what we're just going to pay for extraction. So that could be a point of advocacy.
I think that's a perfect segue to in our next little bit of time together to think about next steps in terms of comment. I mean, I think I'm assuming that Open will absolutely submit a comment and that we will work diligently to get, through the various NRTs as well as the regional groups to get additional comments from that. I know Melissa's group, I know there's a lot of comments being drafted right now. Chelsea, I'm assuming you guys are doing comments as well. What do you all propose as the process to get Open's comments drafted? And this is where I feel like I need to remind everyone that Catalyst wrote the last set of comments on the whatever. So we are absolved of drafting these comments.
I don't have a comment on that, but I had raised my hand previously.
Oh, I'm sorry. Your hand.
That's okay. Yep, I was using the old fashioned and the.
Oh, there it is. I had you covered up with my notes.
Yep. So at any rate, I just wanted to pick up on something that Dr. Glassman said, and maybe the people who are good at drafting comments that will be impactful can consider it and figure whether it should be included or not. But when I listened to these comments, and I did laugh at the let's just extract everybody's teeth and then there will be no dental infections, because I just finished watching the Nick, which was at the time when they did extract people's teeth for various crazy reasons. Good series recommendation. But the thing I want to say now is, I know it's a much longer term disease, and I know that the science is perhaps not as well established, but I feel like if we're going to make comments about this, we have to talk about other things like dementia and some of the evidence that's there. I mean, I know everybody wants the whole thing and there's going to be some incremental change and this is a thing, but I think it would be a wasted opportunity to not at least allude to some of the other ways that this would save Medicare and Medicaid money.
Thanks, Deb. I think that's helpful. And also, I want to give huge apologies. I didn't realize that half my screen was covered up with my notes. So if folks were raising their hand or in other ways trying to get my attention and I was ignoring you, I was not intentionally ignoring you. I could only see half of my screen. So I think those are terrific points in terms of what should be included in the comments. And I know we'll have an opportunity to have great templates from the national groups to use for Open's comments. I still would like to put back on the floor that we're going to need a process to get ours done, unless Open would just choose to sign on to another organization's already published comments. Yes, Paul.
Well, it seems like there's two avenues here for preparing comments. One is sort of the science. So the idea of, and I'm seeing it in concentric circles based on what Deb just said. You have the science of what are they trying to do in terms of closely tied to a medical procedure, which has to do with dental infection and what kind of things cause dental infection and how you present them. So that's sort of the immediate, you're about to have an organ transplant. Deb's raising the issue of prevention, of preventing future problems that could also cause either damage to the organ transplant or damage that would lead to an organ transplant or other things like that, which is obviously a kind of a little further far out circle if you're talking about the evidence. But it seems like the first thing is evidence. And I want to ask Chelsea, I'm assuming the ADA is going to be gathering that evidence. I don't know if we want to reinvent that wheel, but if you don't think so, then there's enough people, I think, involved with Open who have access to the scientific background to pull some of that together. And then there's a science and the politics, I think, are the two sort of approaches we need to think about.
But before Chelsea answers that, are you implying that before I get dementia, I can have a brain transplant?
If you wait long enough, you can have everything replaced. I figure I'm turning mostly bionic now. I've got a hip replacement. I've got artificial ears and eyes. And so we're on our way, Deb.
I mean, all the extra pieces of information you learn on the policy NRT call are very important.
So yeah, it's a good question. And reading through the rule, one thing that's a little bit unclear, or I don't think they're looking or seeking, causal linkage evidence. Really, in any case, at least, just reading the text. So I don't think that's where the bar is set. I don't think we have to reach, I don't think anybody in their comments needs to make that sort of justification. I think the other sort of economic justifications will work and are valid to submit and to consider. Yeah, and I will also comment too, unfortunately, based on the timeline of our process, I'm not convinced that we'll be submitting this in advance enough to share. I'm sure the comments will be shared publicly once they're submitted, because obviously they'll end up being public anyways. But unfortunately, given the timeline that's been shared with us, I don't think we'll be able to share in advance, unfortunately.
And Chelsea, I wasn't so much asking about scientific evidence for the or the reason why preventing dental infection is important. I was more thinking about the fact of preventing some evidence that there's multiple ways to prevent dental infection. And it's not only just an extraction, that other ways to do it. Now, obviously, there's the cost factor. The extraction is the cheapest way to do it. And if they're only looking at the bottom line cost, it's going to be hard to argue that they should have a root canal and a crown, which is going to be 100 times more expensive. But still, I think there's some evidence that can be brought to bear about other ways to prevent infection, which is the goal.
Yeah, and they've really opened that up well in one section, because they've actually like listed out specific service areas and CDT codes. So I think one way to approach that is look at the CDT codes in the service areas they've mentioned and figure out, like, okay, now they've opened this door, which of these can we attach to any dental care that might be associated with these other medical conditions that we are proposing for eligibility. I'm getting in so much trouble.